Okay, cool. Hi, everybody. Can we all scan the QR code? So this is a bit of an experiment of a presentation. I apologize if it goes all wrong in terms of the tech, but hopefully it'll be fine. So I, along with a team, are doing a project on coffee and cases, and I've told you all about it loads. I don't shut up about it, so I'm not going to tell you about it now. We're just going to do a lovely quiz, and hopefully through this quiz we'll see a little bit about what we're doing with the project and showcasing some of the ways that we're processing coffee and cases output. So the quiz is going to be 25 questions. All the questions are inspired by Coffee and Cases learning summaries. They're MCQs and short answers. There are more points if you answer the question rapidly, which is quite interesting. And there'll be a leaderboard up every 5 questions. So in the interests of psychological safety, if when you put your name in, you could just not use your actual name so no one knows who's on the leaderboard and it's all a bit of a secret. Because I think it would be a bit embarrassing to have your name up there. All right, let's do it. As I say, this is an experiment. So how many players have we got?
So we are doing our own name, or we're not?
So I mean, you can put your own name if you like, but I just don't want people to feel that they need to, and then they'll be on the, on the leaderboard and they don't want to be, kind of thing.
I've used your name.
I mean, yeah. I mean, it's a quiz, so you could do a quiz name.
People online are just logging in.
Great. Cool.
Psychologically safe.
Yeah, is everybody feeling psychologically safe? Tell me when there's a green light, mate.
The speed is the key point.
So, well, correctness is the key.
Yeah.
Just a note as well. So the way it's going to work, question, you guys answer. I'm going to tell the answer. I'm going to give you the answer straight away. And then there's a tiny bit of blurb. It's definitely not going to be a very deep dive. And there's going to be a lot of signposting to resources that I found very useful. Essentially, these are 25 of my favorite learning points from the last 8 months of Coffee and Cases. All right, let's do it. You've got 20 seconds. All right, so cool. So just a tiny bit of description on this one. So this is alpaca. This was actually one of the first Coffee and Cases that I attended. I remember it was Cliff who was the DRC. And I just think this is a really cool tool to just make you think a bit about patients who have refractory shock. So A, is this actual hypotension? Check the transducers. Put the blood pressure cuff on the other limb. L for lines of other vasopressors going in. P for POCUS. So do an ultrasound. Is there adrenal insufficiency? Do we need to give steroids? What's the ionized calcium? Could this be anaphylaxis? I think that's really useful. And that's Cliff tweeting it. All right, so question 2. Everybody's ready? Go. So patients on NIV and they're receiving BiPAP. What is the IPAP? All right, so interesting spread of answers. So this was an important learning point for me early on, something that I got wrong, and it was discussed at a Coffee and Cases. So on our Hamilton, when you're doing BiPAP, the pressure support is additive on top of the PEEP. So if it says 10 and 5 on the Hamilton in a patient you're giving NIV to, it's actually IPAP 15, CPAP 5. Does that make sense? That was just I thought a kind of really easy mistake to make, so I included it as one of my favorite learning points. And don't worry about scanning these QR codes. All of this information will be A, up on the blog, and B, hopefully these will be spread as actual snippets, Coffee and Cases snippets around the bases. And you'll hopefully be seeing lots of snippets around all the bases very soon. But this is a great blog post written by somebody, a registrar in the past, going through all of the details around the Hamilton. All right, question 3. Everybody ready? Let's go. So what does the term ducts in the pond refer to? This is in the aircraft. Probably should have specified that in the question. In the aircraft. When you hear that on comms, what does it mean?
Are you just trying to...
All right. So
You do so badly.
ducks on the pond, which I have heard once, is code for everybody on the aircraft needs to be aware that there's either a patient or a patient relative on comms, so they can hear everything we're saying. So we need to behave ourselves. Okay. Sorry? All right, so question 4, let's rapid fire go through it. What does this winch hand signal mean? I hope you can see that clearly. So it's like a chopping motion in front of the body. This is the hand signal. All right, so interesting. We need to do our statics, potentially. So I'm not going to go into the hand signals. What I'm going to do is signpost you to something that I recently discovered on the item app. If you go on the item app and you go onto the emergency action card list, in that list, all of the hand signals are there. Super useful, particularly if you're on the way to a winch, I'd imagine. So just a really good resource, I thought, that was sort of hiding away where I wouldn't have expected to find it. Okay, so question 5, let's go. What's the correct order of Max Fax hemorrhage control interventions as per our SOP? It's quite a tricky one, I think. So this is as per our SOP, not suggesting this is an absolute. This is as per our clinical practice standard. All right, so this is a screenshot of our clinical practice standard. So need to be tubed, need to be collared. You then realign the midface. You then insert the nasal apostats, but you don't inflate them. You then place the bite blocks in. You then gently inflate the balloons with water or saline, and then you apply gentle traction, and then you reassess. So that's the order that is suggested in our SOP. Everybody happy? All right. This is a really good video from Jeff Healy. It was on our VLE, and it's also on the website, and I had a look at it recently, and it's excellent, and I'd highly recommend revisiting, especially if you haven't done this procedure. I know that Namdi has this year. All right, this is the leaderboard. Robbie. Wow, Norman Bates screaming ahead. Okay. Question 6. What is the mechanism of action, not actin, action of metaraminal? Okay. So this was an interesting learning point, I thought. This is also a screenshot of one of the snippets going out as a tweet on Twitter, just so you're aware there is a social media presence of this project. But yeah, so I thought I also would just share this. This is a really interesting podcast that was recently released by FemCast. Has anybody listened to this? Definitely a good listen. It's obvious. I'm not suggesting that we should start using vasopressors in trauma. I'm just saying it's quite an interesting listen, and there's been a lot of chat around it recently, particularly in the last M&M. There was some interesting discussion around vasopressors, and yeah, I'd implore you to check it out and have a discussion on our big WhatsApp group. Okay, question 7. Which of the following is not an indication for a serratus anterior block? All right. So did we get the right answer there? Did you see the right answer? You did, fine. So yeah, okay, so this is a bit of blurb. So serratus anterior block provides effective local analgesia for anterior, anterolateral, and lateral rib fractures. And you can also use it when putting a chest drain in. It's definitely a skill that I have not got, and I would really like to learn it. And if there are any anaesthetic doctors who would be happy to give me a tutorial on it in the coming weeks, I'd be hugely appreciative. Question 8. When retrieving a patient with an EVD, where should the transducer be positioned? To what anatomical landmark? So the correct answer is the tragus or the external auditory meatus. Cool. So I thought I'd include this just because I haven't looked after a patient with an EVD yet. I'd imagine it's reasonably rare for us to be retrieving a patient with an EVD. But yeah, quite a crucial point. Keep the transducer at that level. Otherwise, you can have major problems with ICP. Okay, next question. Double pumping a norad infusion for transfer. So there's 20 mils of single strength running. You are switching to double strength. What rate should you start your norad infusion? So I appreciate that there's probably quite a few different approaches to double pumping, but as per our recommendations, should be 5 mils an hour. So this is taken from an excellent blog written by Sarah Aldington, which is up on the website. You can get it with that QR code. And I'll allow you to read that little snippet from it. Everybody happy with that? Any questions? Next question. So can Rocuronium worsen shock in a patient with intra-abdominal bleeding? Okay, that's interesting split of results there. So this has been talked about at multiple coffee and cases that I've been involved in, and it's been comprehensively debunked. And I thought that was really interesting because last year at the Royal London, I had a small teaching session with a consultant I really admire, and they were very much believers in this bit of dogma, which I thought is interesting. So yeah, it's dogma apparently. I did try and look online for it being more formally debunked. I couldn't find it. If there's anyone out there that maybe could post something on the WhatsApp group, that would be great. And I can put a QR code on this snippet. All right, so let's look at the leaderboard. Tight. Cool. Great work, guys. In isolated penetrating torso trauma, our clinical practice standard recommends targeting which of these physiological endpoints? Systolic more than 100, systolic more than 80, or a palpable radial pulse, or verbal contact / palpable central pulse. Penetrating torso trauma. Cool, so that's the answer. And this is an excerpt from our clinical practice standard. So the reason I included this as a snippet is that there was a really interesting discussion I was part of a couple of months ago where we were talking about blood pressure targets in penetrating trauma, and some evidence was discussed that if you go below 110 systolic, you're in quite a bit of trouble. And I just thought that was an interesting contrast to what our SOP says, and also what London HEMS SOP says. And is it that this evidence isn't being bought into? Anyway, certainly a discussion that I'd like to hear some clever people talk about. So maybe thoughts in the WhatsApp group would be most welcome. So you're going to insert a chest drain into an obese trauma patient. In the portex drain kit, there is a syringe. What is that syringe for? I think, yeah, I feel bad. Yeah, open the valve. I'm sorry. That's out of my control. So the correct answers I put: prime the flutter valve, prime the Heimlich valve, open the flutter valve, open the Heimlich valve. Those are the 4 correct answers. So I do apologize for those that have put entirely reasonable answers and they're incorrect. So yeah, just be aware of it. I've never put one of these, actually used one of these in practice this year, but you're supposed to use the syringe to prime the valve so that the kit works. Just worth being aware of. All right, question 13. When navigating the road ambulance with lights and sirens, the navigator should call out direction, distance, and what other detail, as per Sam Immons. Street name. Yeah. So left turn, 300 meters, John Street. And you're just supposed to do that, say nothing else, keep the cockpit pretty sterile. And I was doing a job down in Wollongong with Sam, and he taught me that, and I thought that was a really useful snippet. Cool. How should the patient with a humeral IO in situ requiring an ipsilateral thoracostomy be positioned? Nice. So this is something that we received a lot of teaching on, but a really useful tip I've found since watching this video, another bit of brilliance from Cliff, is thumbs down. So internal rotation at the shoulder can be achieved simply by making sure the patient's thumbs are down, and that reduces the chance of dislodgement of the humeral IO. Sorry?
Thumbs up.
Thumbs up, Mum.
Thumbs down, put them up.
Thumbs up, thumbs down.
Put 'em up
Thumbs
like
up, bum. Okay, keep saying it louder. Moving your thumbs towards the bum.
Oh, right, fine,
Internal rotation.
fine. So if I put it, is what I put wrong?
No. That's like
Yeah.
malversation.
Mal,
Thumb up,
mate.
bum, is that your thumbs are going towards your bum.
Ah,
So
fine,
internal rotation.
fine. You've made me panic for a second there.
Just making it a bit more.
Okay, so just on the subject of humeral IO, this is one of the, I think this was the debut Coffee Cases Snippets tweet. Lots of action on that tweet. But just something that you could also consider using a triangular bandage to tie the arm to the opposite handle, opposite waist of the stretcher, so that you keep the arm in internal rotation.
Yes, it's getting a lot of views. Oh, so terrific.
Okay, so question 15. Right, read carefully, chaps. 30-second drills when no identifiable structures can be seen. So you've done suction, you've inserted deep, and you've slowly withdrawn. You've changed the blade size, you've changed the blade type, you've changed your eye level. What else is on our clinical practice standard when there is no identifiable structures? Binge operator. So I've included this one just because one of the Coffee and Cases summaries prompted me to go and check out our clinical practice standard for pre-hospital anesthesia. And quite interestingly, this is an excerpt from the clinical practice standard. They divide up the 30-second drills into what you're seeing. Now, in practice, I'm not suggesting that we should be being really rigid about how we're going through our 30-second drills, and I'm sure there are lots of experienced people in the room have different ways of doing it. But I just thought that was quite logical and quite interesting, dividing it like that. And it's just something to be aware of and maybe revisit when you have time to look at the SOP. So there's the leaderboard. Norman Bates doing well. Which type of electrical current is more dangerous? AC or DC? Great. So why is it more dangerous? Why is AC more dangerous? DC, or direct current, produces a single spasm, and alternating current, or AC, produces tetanic contractions. So if somebody grabs something which is an electric source and producing an electrical injury, they can't let go. So you have a higher exposure. Question 17. It's only 24 questions. I thought there was 25. Fine. So in this label diagram, which number corresponds to the part of the device involved with oxygen delivery? Can everyone see the image?
They're not numbers.
I was on it. Yeah, that's my bad. Cool. So this is the end-tidal CO2 nasal cannula. I think really the point I'm trying to make here is that it's rubbish at delivering oxygen. Reason being, the big reservoir in front and the nasal prongs are measuring CO2, and there's just these tiny little holes which sort of waft oxygen near to the nose. So it's just, they're rubbish for delivering oxygen. They're good for measuring end-tidal CO2. So just something to be aware of. Question 18. New South Wales Police use jacketed hollow point bullets in their firearms. What do we need to know about these bullets? We don't necessarily need to know, but important to know. So they expand on impact. So New South Wales Police carry them, and their point is that they deliver controlled expansion because of their shape. So they cause major damage when they are inserted into a human body, and they minimize collateral damage because they stop as opposed to going through and through. So if someone was shot by the police, bad news. Question 19. It's a bit clunky in between questions, isn't it? Next time I'll change that. What is our best clinical indicator of peripheral perfusion? Yeah, so that, again, sorry, that SpO2 is probably reasonable. So this nice and simple one. So our best indicator of good peripheral perfusion is a good trace on the SATs. 20. So aircraft comms. Which channel do we use for down the wire communications? Yeah. So just definitely look at this blog post in your spare time, which this QR code goes to. It's a really good one, and I think it's a collaboration between a registrar and some of the crewmen, and it goes into detail about what we need to know. Com 1 and Com 2, air traffic control. Com 3, agencies on scene, including hospital security, so that's the one we'll hear the most. Com 4 is the government radio network, and that's when we're communicating with the crews on scene, ACC, and down the wire. That's the big one. Com 5 is the mobile that we carry in the aircraft making calls to the DRC. So that's my understanding of it. Is that reasonable to others who might be more experienced?
Not really.
No?
None of them are channels. They're comms boxes.
Fine. But does that make sense?
Well, you're right in that that's where you could put any of them in any of those boxes. That's how we have it set. But the
Fine.
question regarding channels.
So it's just incorrect terminology on my part.
Sort of, yeah.
You did get it wrong, Ken.
I've got all of them wrong so far.
So if I change this, if I for this was a really important one for me because I've really struggled with this all year and I was trying to make sense of it. Like this is a standard how the comm box is arranged in all of the aircraft for us on the doctor's side. Is that or
Correct.
across the aircraft?
Yeah,
across the aircraft.
That's right.
Fine. But what's the issue with it? It's the terminology of using channel.
What channel you're on.
Right.
And so the channels are within the radio itself. So the GRN radio has a huge number of channels, and the one that we use during winching is
sure. But for the purposes of the doctor sat in the chair in the helicopter and you're looking over at the comm box, that makes sense.
At the comm box, yeah, but your radio in your that you're going to be using on the wire, will not have that. It will have a different channel on it. So you need to make sure that your radio is on the helicopter channel while you're winching, not on an operational channel.
Okay.
So that you can talk to the crewman while you're winching, because that's more important.
Cool. Well, maybe we could at some point sit down and slightly adjust this so before it gets distributed across the basis. Cheers, man. Okay, so here we go. We've done another 5 questions. Fine. All right. Questions, anyone? How do you make up push dose adrenaline? Wait. Sorry, I went too fast there. So the answer was the first answer. So hopefully everyone knows how to do this, but I just thought it was a useful reminder. So 10 ml syringe, fill it with 9 mils of normal saline, get a cardiac arrest syringe, adrenaline syringe, and then withdraw 1 mil from that. And in that syringe, original 10 mil syringe, you have 10 mics per mil, and that's really good to use for as a push dose suppressor or push dose adrenaline. Cool. Nearly at the end. Got an amazing prize for the winner. So, what are the immediate clinical priorities? And the order is relevant. We're out of time. Fine. So again, this is interesting that people didn't choose the second option. I went on our SOP here. So patient is rescued. They've just got into the aircraft, and my understanding and what I'm reading is as what my job's to do is get the eye gel out of the DEA, put the eye gel in, deliver 5 rescue breaths, start CPR, get to ground, and then start from scratch. Suctioning is probably not a win. At least that's my understanding reading through that. Anybody got any thoughts on that? Eye gel ventilation as opposed to suction, eye gel ventilation. Just get the eye gel in, ventilate, rescue breaths, CPR. Any consultants want to weigh in on that? Because I don't want to be saying something that is delivering dodgy information. But that's what my interpretation of the clinical practice standard there. Cool. All right. Penultimate question. So what buttons do you need to push on the Hamilton to perform an inspiratory hold maneuver with the view of working out the plateau pressure? So Richard. Major clank. Sorry, everybody. It's quite difficult to transfer the PowerPoint to the app. Anyway, that's my bad. Does anyone want to shout the answer? Like, what's the icon that you? The lungs one, yeah. So yeah, to do an inspiratory hold, you press the lungs button for 10 seconds. Then you press the two arrows facing each other at the top left of the graph to freeze the graph, and then from there you can use the cursor to work out the plateau pressure.
Or if you've done that, it'll come up in monitoring screen 3 as plateau pressure.
Okay.
Yeah.
Cool.
There's also a little equation you can use that balances on protein.
Cool. Maybe we could have that reposted on the group. That would be great. Yeah. Final question. Sorry about question 23. The paediatric bougie fits the size 5 ETT. It is too short for the size 6 ETT. True or false? Cool. So the PEDS bougie, it fits the size 5 perfectly. It's too short for the size 6. It doesn't fit the size 4, and it can be used nicely for a front of neck access with a size 6. Just thought that was quite good information, quite simple. Cool. So should we have a look at the leaderboard? Who won? I hope everybody's... I'm sure the next time I use this app, it'll be much smoother. All thanks. Cool. Norman, if you come and find me afterwards, well, I'll give you your prize.
Might find this few of them.
So, yeah. So I just thought very, very quickly, I'd share with you our performance. So with the Coffee Cases QI project that's currently ongoing. So numbers are looking really good. So these are the two big things that we're measuring. So how often we are filling in the form after Coffee Cases. Now, that number is slightly worse in May than it was in April. And there has been a bit of a drop off in the last couple of weeks. And I think mainly because people are doing, there's statics and airway currencies going on quite a lot at the moment. Please, can you remember, if you're a registrar or consultant on that day and Coffee Cases does not go ahead, if you could just try and remember to scan the QR code and just click Coffee Cases didn't happen, and then give a very brief reason, just to kind of acknowledge that there needs to be a form filled out, and then that number will improve. But the really important number is this one, and that's how many snippets are being extracted from the forms that are filled out. And I think that's really encouraging. If you look at what was going on between August and January, 3.4 usable learning points a week, and now we're up at 23.2. So there's clearly been a shift in how we're doing this process. And I think it's largely because people are understanding what is good to document. If you have a discussion about a case, what's really good on the form is to extract a point from that case that everybody can read, even if they didn't attend Coffee Cases. So a standalone learning point, as opposed to we discussed this. Signposting that a discussion that happened, or signposting something really case specific that's not really usable outside of that meeting. So if everyone can just be aware of that, and we can increase even more, the output of the projects, and hopefully in the coming weeks, hopefully before I leave in August, you'll start to see how these snippets are being disseminated across the service. So currently in Wollongong, there's a rolling slide deck playing them 24 hours a day, and it's going down quite well. Hopefully we can get some up in the Bankstown base and the Orange base as well. And of course, there's the newsletters that are being produced now and the occasional blog posts as well. So I think there's been some really positive movement with this project.
Yeah, so massive thank you for driving that. It's really good to be able to learn people's experiences. And if you're not there on the day and you don't have time to go back and have a look through the stuff yourself, having something there on the screen, I think it's really fantastic.
Yeah, and I think as well, like it can be used. I think that the idea of having a slide deck up with information just there for people to passively consume is the other educational outputs from this service could easily fit into it as well. So stuff from the airway audit, stuff from the M&M. So just, I think the sky's the limit, really. Anyway, thanks very much, everybody, and cheers. See you soon.